So, good evening, everyone. Are my slides visible?
Yes, Manish.
Okay. So, at the outset, my gratitude to Dr. Bala and Dr. Vineet for organizing this meeting at the end of this year uh, after a gap of 2 months, and then asking me to present our experience that how we are dealing with this high flow fistula as a nephrologist without being dependent on the surgeon. So we all know that AV fistula is lifeline of our dialysis patient, and it is considered to be the dialysis ideal vascular access.
Manish,
But
please get closer to the mic. Yeah.
Okay. Am I not audible?
Yeah, I mean, if you are closer, I think it'll be better. It's fine now. Carry on.
Okay. Okay, so we will all agree that once we have made fistula and once this fistula is functional, we often ignore, we as nephrologists as well as our dialysis team also ignore unless it starts giving us any problem. And that is why there are recommendations that we should be doing a regular monitoring and regular surveillance of these fistula. Ideally, it should be done at each dialysis session, a quick examination of the fistula, but at least on a monthly basis, a detailed examination is what is recommended, and then we can use obviously the help of ultrasound and other modalities if we are finding any problem. So the point here is don't ignore your fistula once it has started functioning, because by the time you recognize the problem, it will already be too late and you will have difficulty in intervening. So point here is about dilated tortuous fistula. We are not talking about other problems which are associated with fistula. So dilated tortuous fistula, you can see in this picture, can have aneurysmal dilatation. There can be skin ulceration because of this aneurysmal dilatation and repeated functioning over same segment. And then you will on examination find a hyperpulsatile kind of vein uh, and with minimal fill. So this kind of dilated tortuous fistula, which Dr. Bala has also shared an image of this fistula a few days back, can be because of various reasons. And so one of the obvious reason is of this dilated tortuous fistula is that there is stenosis in the outflow segment, somewhere distal to anastomosis, or there is a central vein stenosis. And because of the resistance to the flow, the proximal segment is getting dilated and tortuous. However, what is often ignored that one of the commonest reason of this dilated and tortuous fistula is high flow fistula. And if you assess the flow measurement as was demonstrated by Dr. Ajay, most often than not, you will find that this fistula is having high flow. And sometimes, in our experience, about 30% of cases will have combination of both high flow fistula as well as stenosis somewhere, either in the arch or in the central vein. Now we come to high flow fistula. What do we mean by high flow fistula? So, if you are aware of the rule of six, a flow of 600 mils per minute is required to say that this fistula is now mature. And there are a normal flow of fistula is defined anywhere up to 1000 mils per minute. So there are various definitions in literature. If you go across, people have defined it in variety of ways that how they define a high flow fistula. So one is an absolute cutoff of fistula flow measurement, like what has been demonstrated again by Dr. Ajay previously, that if you demonstrate a fistula and the flow is more than 1 to 1.5 liters per minute, you can call it as a high flow fistula. Now, most often these kind of definitions will be applicable to asymptomatic patients, like you just are doing a surveillance or monitoring and you will find, but your patient will not have uh, problems at this kind of rates. The usually problems start when the flow goes beyond 2 liters or somewhere around 2 liters or 2.5 liters or so. However, people have also advised to use a ratio of cardiac output to the fistula flow, and that is how this definition of 1 liter has come, because normal cardiac output is said to be around 5 liter, and if you take 20% of that 5 liter, it comes to around 1 liter. So you measure the cardiac output by doing echocardiography, And also you do a flow assessment. And if your fistula flow is more than 20% of your cardiac output, you call this fistula as a high flow fistula. So these are the two definitions. You can use either of them. Both kind of definitions have been used in literature. What are the causes of high flow fistula? And the most common cause is the surgical. When you are making fistula, when all of us are making fistula, what we want is to achieve a thrill at the time of table, at the time of surgery, and this thrill gives us a thrill. However, what we often ignore is that for achieving this thrill, sometimes we become overzealous and we make a large arteriotomy, and this is supposed to be the most common cause of a high flow fistula subsequently. However, what people have also said that the compliance of the arteriovenous system is also deranged because of the uremic milieu, and also these patients are cardiac patients. Somehow their veins get more accommodative; they keep on getting dilated, and because of this compliance of the arteriovenous system, uh, there is a increased flow which is going to the fistula. And then one of the common reason is also if, as I've said previously, if there is a distal stenosis in arch or in central vein, then it can give resistance, and because of resistance, distally there will be at the anastomosis side, they can occur dilated tortuous fistula and resulting into high flow fistula. Now, so what I have said is that both things are becoming a vicious cycle. So on one hand, you have a outflow stenosis, maybe in arch or in central vein, and on other hand, there is a high flow fistula. Now, which one is leading to what? Now, and this is my hypothesis. This may not be proven scientifically, but what I feel is that it is predominantly high flow fistula which is resulting into your venous stenosis. Why? Because when there is high flow fistula, this causes more damage to your endothelial cells because of your pressures, and because this kind of stenosis especially occurs at the branching sites or at the site where they are taking a turn, so where there is lot of turbulence, and because of this high flow fistula, this turbulence increases and this causes damage over a period of time and resulting into stenosis. So other way around, that overflow stenosis resulting into high flow fistula can also occur, but to me it is less likely as compared to high flow fistula resulting into outflow stenosis. And this is important to understand because when we are dealing with these patients who have both combination of fistula, which is high flow, as well as central venous stenosis or arch stenosis, how we should deal with these patients, and we will come to that in a minute. So, if you have a high flow fistula, what can be the problems in your patient, or how can your patient present? So, obviously, there can be excess recirculation as well as cardiopulmonary recirculation. Cardiopulmonary recirculation is also often ignored because suppose your cardiac output is 5 liters and 2 liters or 2.5 liters of that is going into the fistula itself. So remaining amount of blood will be going throughout the body. So the uremia, which that blood will be draining, will be less, and this is known as cardiopulmonary recirculation. So in addition to your excess recirculation, there will be cardiopulmonary recirculation, which will result into inadequate dialysis, and this is most common kind of presentation, and most of your patient, if you analyze them, will have inadequate dialysis. Our patients, we have found they will be cachectic despite getting thrice weekly or sometimes even daily dialysis. They will not be having good appetite and having lot of uremic symptoms. So keep this in mind if you are dealing with an inadequate dialysis patient. Then they can be dilated tortuous fistula, like I have shown before. There can be aneurysm dilatation, megafistula, and it can result into distal stenosis in the veins, central vein, or in the arch. Then another problem is high output cardiac failure because most of the flow is going to the fistula, and the heart is then accommodating itself to pump the blood to other organs, and this results into high output cardiac failure. Another common and often ignored symptoms is that these patients will have prolonged bleeding after finishing their dialysis. They will require a lot of compression and compression for a prolonged period of time. And sometimes we have picked up hypofistula because of this symptom only. The patient come to us that, sir, the bleeding is not stopping even for 1 hour after I finish my dialysis, and that is how you should pick up your hypofistula. Other problems, you can understand that they can be accessory vein formation, there can be venous hypertension resulting into limb swelling, there can be venous ulceration, there can be steel phenomena because all the blood is going through the fistula and there is limited supply in the distal part of the fistula. So there can be occurrence of steel phenomena. There can be vascular gangrene and other kind of things can also occur. So this is how a patient can present. However, as I've said earlier, most of these patients will be asymptomatic in the early stage unless the flow is really high and then they start developing symptoms. Now, this is again my hypothesis is that once you are dealing with the dilated tortuous fistula, what we do is that we always worry about stenosis in cephalic arch or in the central vein stenosis. We go for venography and we find venous stenosis and we go for venoplasty. So now what I say is that you do whatever you want to say, but before you deciding to go for venoplasty, first decide if your patient is symptomatic or asymptomatic. And in symptomatic patient, like the symptoms which I have discussed earlier, you assess fistula flow in addition to your venography. Now there can be two conditions. There can be isolated venous stenosis without high flow fistula, then you can go ahead simply and do a venoplasty. However, if there is a outflow stenosis along with a high flow fistula, then please don't go ahead with venoplasty. What you should do is that first you have to take care of this high flow fistula by whatever means you want to take. Because what will happen is that if there is a stenosis and there is a high flow fistula, now you are opening this stenosis. So whatever resistance this stenosis was giving to flow will now go away. And because of the resistance which will go away, this fistula will further have more flow. And that is one of the reason why your patient goes into congestive heart failure after opening up the vein. So whenever you are dealing with these kind of patients, always assess the flow. And if you are finding an high flow fistula, first tackle the high flow fistula rather than opening the vein. Now, how to tackle this high flow fistula? And if you go through literature, there are various kind of procedures which have been advised. So, balloon assisted intraluminal procedure, which we all know as Miller procedure, where a balloon is inserted intraluminally and dilated to a certain whatever predefined volume, and then a band is applied externally over the dilated volume, and then the balloon is deflated and the catheter is removed. So this is what is known as Miller procedure. Then you can do external placement of polyester band, vein plication, which is usually done by our surgery colleague. And if you are not able to succeed by all of these, because all of these, even the procedure which I will be demonstrating, will have a high chances of recurrence. Usually they have high chances of recurrence. And finally, if you are not succeeding with any of the measures, then there is no other option other than closing this fistula and making another fistula. Now, what I'll be demonstrating you is this external dilated assisted bending, which we all know as EDAP, which is a simple technique. It is a minimally invasive technique which can be done by us, by nephrologists. Obviously, in the initial part, you have to keep a surgeon as your backup because you are new and you don't know how to deal with this hugely dilated veins. So just keep surgeon as your backup, but you can easily do it. I will be demonstrating it. So what in this technique we are doing, that we are putting a band externally. We are not going internally, intraluminally in the fistula, just an external bending with the help of dilators. And these are the dilators which are used for placing your tunnel catheters. Usually the 10 to 12 French dilators we are using, minimally invasive with low complication rates, does not require a big surgical backup or expertise. So we go to the video demonstration of this procedure. So this is the same patient which picture I have shown previously, and you can see there are dilated tortuous veins with aneurysmal dilatation, skin ulceration, and hyperpulsatile vein. if you can visual, if you can appreciate this hyperpulsatile vein. So what I have done here is that I have already cleaned. Before that, the flow measurement was done, which was around 3 liters in this case. So this was a high flow fistula. Venography was done, which was showing a mild capillary arch stenosis. So there was a combination of both the things in this case. But whenever there is a combination, the first thing you have to deal is you have to reduce the flow. And how we have done is by this EDAP procedure. Now what we do is that we clean the segment and drape it. After cleaning and draping, you put a local anesthesia and put a superficial incision. After putting a superficial incision, you do a superficial dissection over this dilated venous segment. This incision should be close to your anastomosis segment, and then you do a careful dissection, and you remove, because these are usually long-term fistula, they will have a lot of fibrosis also there. So gradually and carefully you remove the fibrotic thing and you isolate the venous segment. Once you have isolated the venous segment, you pass your artery forceps beneath it and put a loop over it so that you isolate the venous segment. So here you can see this is the dilated venous segment which will be bending. So we have already passed a loop beneath it, and then again one more loop will be passing. So idea here is to expose around 3 to 4 centimeter of the venous segment, because this much area will be requiring for putting the bending. So you put another loop after careful dissection. Now problem here sometimes can occur is that sometimes you will not be able to delineate where is the fibrosis and where is the vessel wall. Here you will come to know with experience only that how a careful dissection is required. So once you have isolated these 3 4 segments, 3 centimeter or 4 centimeter segment of vein, then we can proceed with our ligation. Now for ligation, we require a proline 30 suture. So you remove the needle part of it because you don't require any needling here. So you take 30 proline and you put a artery forceps again, just like you were putting for taking the loops, and take out your suture from below, right? And then you put this, I will show you further also, you put this dilator over the venous segment and put a 1 knot over this dilator and tighten it as much as possible, closing the flow of fistula completely. There should be a complete closure of fistula. Once you have tied first knot, ask one of your assistant to hold that knot and put another knot, because this sutures are slippery. It will slip if somebody is not holding. Once you have put 2 knots, you remove this dilator. Now this is important step because you don't want to close this fistula for too long, and because if you remove it too early, after one knot it only, it will slip. If you put 2 knots and then remove it, it will not slip. And once you have removed your dilator, after putting this 2 knots, then you can put further 3 to 4 knots over it. So take a minute, take some few seconds to look at into this. So we are tying a knot, somebody is holding it, and then we are further tying further knots over it. So this is the kind of stenosis we are making in the fistula segment, in the venous segment. So this is the first band which we have applied. Usually 3 bands are required like this to achieve a meaningful reduction in the fistula flow. So once you have put the knots, you can remove the excess fistula and put another band, like you can visualize here. I have taken the suture from below. Now we are putting the dilator over here and closing by the first knot, closing it completely, obstructing the flow, making it 0. Now somebody will hold this knot and I will tie another knot, and then we will remove this dilator. Okay, and then further you can put another 3 or 4 knots over it so that it stays there. So I have already put two ligations, and this is the third band which I am applying. So usually I put three, but we also do on-table ultrasound and see how much reduction is there. If we find that reduction is not sufficient or meaningful, we can put more also. So we have put these three bands here, and this is a picture after banding. You can see there is one band here, another one here, and third band here. Now you have to usually you have to dissect, you have to do a good dissection, because what will happen if there is lot of fibrosis over venous wall, this sutures will slip and come in a single place. So you have to avoid, you have to keep a distance. So usually 1 centimeter apart in a 3 to 4 centimeter segment of vein, you put these three bands. And as I've said, we do a on-table Doppler assessment to see what is the flow reduction. And in this case, if you see the reading, this wave pattern is not very good, but we usually take three or more to see that there is a significant reduction. And usually what we have observed that at least there is a 50% reduction on table. So if there was 3 liter, we expected it to reduce to around 1.5 liter. It reduced to around 1.3 liter, which was as expected. And then over period of time, over 1 or 2 week period, this will further reduce and it will come to around 1 to 1.2 liters. This is what we have observed. So once you have done this, you can close your opening, your surgical incision, and then you can monitor this patient. So what was our experience? So we have done around 16 such ligations or bending, and this is the experience of first 13 patients which I am sharing with you. So mean age of around 39 years, 3 patients were diabetic, a dialysis vintage mean of around 30 months. And you can see that 4 patients had already undergone venoplasty. So despite undergoing venoplasty, they had this persistent problems and persistent high flow fistula. Out of these 11, 11 were brachiocephalic and 2 were radiocephalic. And 9 patients had hypertension, venous hypertension, high output failure. This is with preserved ejection fraction was in 1 patient. Recurrent central stenosis was seen in 2 patients. So these were the 2 patients who have undergone 2 times venoplasty. And again, despite 2 times venoplasty, these patients had persistent symptoms. Nobody has noticed actually their high flow. And then when we noticed their high flow, we uh, took care of this high flow fistula. So around 60% of our patient had excess recirculation. 60% had Catholic arch stenosis. 1 patient had central venous stenosis, and about 50% of our cases had inadequate dialysis. And this was our results. So mean arterial diameter, and this is about brachial artery diameter before the procedure, was 8.7 millimeter, which reduced immediately. This is immediately after the procedure on table, I am saying. So the good thing about this is that you can actually judge the success of your procedure on table itself. So there was reduction from 8.7 millimeter to 6.3 millimeter, and the flow rate reduction mean was 2.5 liter. It reduced to 1.0. So this is also, as I was saying, that usually we achieve a 50% reduction on table, and the excess recirculation subsequently from 14% of excess recirculation, it reduced to 3.1% of recirculation. And this I could found two articles in the literature. The first was in 2013, where they did 7 patients. So 3 was without fluoroscopy. So remaining 4 were Miller procedure and 3 were EDAP. And in 2016, 12 procedures were reported, and they were all without fluoroscopy. That means they were dilator associated bending. So I would share some tips and tricks when you are starting this procedure. So first is you have to be very careful in the beginning itself when you are giving local anesthesia and the skin incision. Why? Because these veins are usually dilated. So what I do is that I usually pinch the skin and lift it up to give local anesthesia. And once I have given local anesthesia, then I can use toothed forceps to lift the skin and put an incision. Because you have to be careful, the vein is lying just beneath the skin and subcutaneous tissue. If you are not careful, you will injure the vein. And this is the vein which is carrying 2.5 or 3 liters or 4 liters of blood flow every minute. You will be in a big trouble if you are not careful handling this vein. So this is very, very important. Be very careful while giving local anesthesia and skin incision. This I have said earlier that you should try to clean the vein wall of the tissue as much as possible, because what will happen is that otherwise, if you are not cleaning it up, the suture will come together and your three band will become one band, which you don't want. You want a good reduction, because at one segment there will be a tight stenosis and other segment will be dilated. So you don't want that. And to avoid that, you should clean your vein wall of the tissue as much as possible. Third important point is that don't close this fistula for too long. So just put two knots and remove your dilator, because if you keep on waiting to put 4 or 5 knots, your fistula will get blocked. The distal segment, because they are already dilated, sometimes there will be huge aneurysmal dilatation and the blood is staying there and you are obstructing the flow. What will happen is thrombosis will occur, and then you will have to go for thrombectomy. So don't close this fistula for too long. Just remove dilator after putting 2 knots as soon as possible. So another thing is put at least 3 band, but you can put more also if you are not finding a suitable reduction on table. So you can put 4 or 5 also. I have till date put maximum of 4 bending, not more than that. And another important thing is this bending should be as close to your anastomotic site as possible, because what will happen is if you do it more distally, your proximal segment will get dilated and aneurysm, because the fistula flow is still high till your stenosis. So you don't want that. So it is good to do the bending as close to anastomosis as possible, so that there is no dilated segment in between. And finally, some people actually what I am doing is that I am bending the artery. What is recommended is that you have to reduce the inflow. Now you can't do reduction of inflow out always, because when I am dealing with radiocapital fistula, like in two patients I have shown you, I then do this bending on the artery, radial artery. But when we are dealing with brachiocephalic fistula, you can't take chance with your brachial artery, because somehow, unfortunately, if you close this for too long and your brachial artery develop thrombosis, your entire limb will be threatened. Because so that is why what we are doing is that when we are dealing with brachiocephalic fistula, we do bending on the venous segment. But when you are doing with your radiocephalic fistula, you can do bending of artery also, because that is ultimately what is recommended is that you reduce the inflow, and you can reduce inflow only by reducing the arterial diameter. So that is why in radial you can handle the artery, but in brachial don't handle the artery. That is what people have also done, that they have reduced the venous segment and not the arterial segment. So talking about complication, our first case was thrombosis, which and that is why I have given you this tip that don't close this fistula for too long, because first time I was also not very sure how to do this and I was inexperienced. I closed the fistula till I tied all the 5 knots. It resulted into thrombosis into the aneurysmal section. We did a thrombectomy and we salvaged the fistula. That is fine, but that is why you should not close the fistula for too long. So till date, we have observed only one complication, that is thrombosis, and that was also because of our technical fault. Other complication is because these are highly dilated and with a very high flow fistula, you should be very careful in dealing with them, because if you damage this vessel, then there will be a lot of bleeding and procedure failure, that you will not be able to achieve a significant reduction. And finally, this problem is with all the procedures which are dealing with high flow fistula, is that you will have recurrence sometime or another, because the compliance of the system is so huge. Whatever you do, unless you close this fistula, there will be no recurrence. But whatever, even the plication of the fistula have been shown to have significant recurrence rate. So these are some of the complications. So finally, to conclude, what I have shown you is that dilated tortuous fistula is an important long-term complication. However, we are tuned to assess the venous stenosis and go for venoplasty whenever we are dealing with this high tortuous fistula. But you should always check for fistula flow before deciding for venoplasty, because then you will be saving the patient from unnecessary expenses also and unnecessary complication also. So what I have demonstrated you is an EDAP is a simple and minimally invasive low cost procedure. It doesn't cost much. At least in our center, everything is available in house, including the Prolin 30 suture is also available free of cost. So actually it is zero cost procedure for us. But even if you are doing only cost which will be required is for the Prolin and some loops and the sutures. So it is a low cost and effective. I've shown you our data, very effective in reducing at least for a temporary period of time your high flow and thereby preventing the unnecessary venoplasty. So thank you very much for your patient hearing. Happy to take any questions for this presentation.